Welcome back to the second episode of secondary amenorrhea. And since that day I left on, I told that I'll be talking about 3 to 4 more topics which may lead to secondary amenorrhea. Most importantly, I'll be talking about PCOS, which is so common nowadays. Basically, this is hormonal plus emotional condition, and we call it hormotional. And I would like to here clarify also that there is a common perception that PCOS and PCOD are two different etiologies or things. But let me be very clear over here. Despite some documents and some, uh, internet things that quite known and acclaimed bodies are saying that PCOD is different and PCOS is different, it is not so. PCOS is actually the name given to a symptom complex, which we will be discussing now. So what is PCOS? Full form, polycystic ovarian syndrome. That is a symptom complex which may arise due to many etiologies which you need to clear. So we identify PCOS and we make the diagnosis based on Rotterdam's criteria. So first criteria is oligo or anovulation, leading to infrequent cycles or amenorrhea. Second is hyperandrogenism or hyperandrogenemia, which may lead to clinical symptoms of hirsutism, acne, elevated testosterone level, and that is known as hyperandrogenemia. Then third is PCO, yani कि polycystic ovarian morphology on ultrasound, and there should be more than 10 subcentimetric follicles in either one or both the ovaries. So any two out of these three criteria will make a person as a case of PCOS, provided we have ruled out congenital adrenal hyperplasia and Cushing syndrome in peri-adolescent age group. And we have ruled out thyroid and prolactin disorder in the entire reproductive age group females. So if we have ruled out congenital adrenal hyperplasia and Cushing syndrome and thyroid and prolactin disorder, and patient is having either infrequent cycles or landing into amenorrhea, or patient is having clinical features of hyperandrogenism like hirsutism or acne, or having a biochemical evidence of elevated testosterone level, or we have PCO morphology on ultrasound, either all three or 2 out of 3, then that female is a case of PCOS. So never ever presume that a person who's coming to your OPD with an ultrasound picture of PCO morphology, rest everything is fine, then she's not a case of PCOS. Second is if one person is just having infrequent cycles or landing into amenorrhea, but she's not exhibiting any features of hyperandrogenism or hyperandrogenemia, and her ultrasound features are also fine, then also she's not a case of PCOS. Dissecting in further, one, what is PCO morphology? It does look like this, where we have a lot of follicles which are less than 1 centimeter. They should be more than 10, either in one or both the ovaries. That's an ultrasound cause. So first and foremost, we have to know what causes PCO morphology. Polycystic ovarian syndrome. So basic etiology is elevated LH, and that is tonically elevated luteinizing hormone. It is not going down because there is no negative feedback from progesterone, which says that yes, your work is finished, now you can go down and let the FSH come in now. But it's not coming, it's not going down. That is why PCO pattern is formed. Second is chronic and long-standing hyperestrogenic conditions in the body. There may be hereditary predisposition also, insulin resistance in some cases, low grade persistent inflammation. That's the latest theory, and environmental toxin which lead to or predispose to development of PCOS. So what are the investigations you know? So always remember there are 3 things that make PCOS a PCOS. One is infrequent menstruation or amenorrhea, which is arising due to infrequent ovulation or loss of ovulation, that is anovulation. So these conditions, that is infrequent menstruation and absence of menstruation, may be one due to anterior pituitary hormonal imbalance. So either there can be hypothyroidism or hyperthyroidism, there can be hyperprolactinemia, This may also be caused due to drugs, especially domperidone, which is very, very common in today's world when we are having a lot of stress. There is a lot of altered lifestyle pattern. We are eating a lot of junk foods and we take antacids and we take it invariably along with domperidone. Then stress, acute weight gain, weight loss, too much of mental stress can lead to infrequent cycle or total absence of cycles. So this is one segment that we need to rule out. Second feature was hyperandrogenism or hyperandrogenemia. So for that, we do Ferriman-Galway score. Now that's a totally different topic that we need to discuss, but let's restrict over here to Ferriman-Galway score we have to do. If it is mild, then no further investigations are needed to confirm that this is arising out of biochemical presence of hyper or more levels of testosterone. If it is of moderate variety, then you have to go for free testosterone level. And if they are also coming normal, then DHEAS level also. But if it is sudden onset, severe, rapidly progressing, then you have to rule out adrenal gland tumor and androgen secreting ovarian tumor. You have to go for ultrasound or maybe CT scan of the kidney to evaluate adrenal glands. So I'll repeat, hyperandrogenism agar hai, it does not mean that there is a high level of testosterone in the body. So you just see if it is mild, so you don't need to establish the fact that it is due to elevated level of testosterone. If it is moderate, then yes, you need to know of what compartment is overfunctional, whether it is free testosterone level, that is ovarian compartment, or DHEAS, that is adrenal compartment. But you have to remember that if it is rapidly progressing, severe, sudden in onset, then adrenal gland tumor or androgen secreting ovarian tumors may be the culprit. There you need to go for further investigation. Then third was PCO morphology on ultrasound. It is otherwise a common exhibition of a stimulated ovary where there is continuous FSH, continuous estrogen, but estrogen is neither going down nor there is a negative feedback. Thus, LH surge is not there and LH is tonically present over there. When there is no LH surge, there is no ovulation. Thus, the person lands into oligo-ovulation or anovulation. But this is a common finding in adolescents, in perimenopausal age group, because there we have persistently elevated high levels of follicle stimulating hormones. And the females who are using oral contraceptive pills, then PCO morphology is common in them too. That is why in adolescent category, taking PCO morphology as a diagnostic criteria for polycystic ovarian syndrome has been withdrawn. We no longer count PCO morphology in making a diagnosis for adolescent PCO. Now, how do we see congenital adrenal hyperplasia? We will see perimenarcheal girls presenting as late onset or non-classical variety of congenital adrenal hyperplasia. There are signs of virilization. It is basically manifesting either in young adult females or adolescents. There is hirsutism, amenorrhea. So remember those two criteria, Rotterdam's criteria. One was hyperandrogenism and another was oligoanovulation. But female can have clitoromegaly also. She will have lots of acne. She will have infertility. So you have to see basically what is the time of onset and are there any signs of realization present or not. Second is Cushing syndrome, in which the features are classical. The female will be having moon facies, lot of acne, thin skin, weight gain, lot of purple marks, pendulous abdomen, muscle weakness, poor wound healing may be there, hypertension may be there. She may have an adrenal tumor, menstrual irregularities, osteoporosis, and skin ulcer. So these three things, acne, then menstrual irregularities, may may lead us to think that this female is suffering from PCO morphology, but we have to identify the real culprit. So when we see the diagnosis is final, we see that patient is fitting into the Rotterdam's criteria. You have ruled out congenital adrenal hyperplasia and you have ruled out Cushing syndrome in perimenarcheal girls. You have ruled out hypothyroidism, hyperthyroidism, and hyperprolactinemia in and across the entire spectrum of reproductive age group, then you are pretty sure that you are dealing with a case of PCOS. So you do the treatment according to the patient profile. If menstrual irregularity is a concern and presenting symptom, then induction of menstruation by using ultrasound, and you can guide yourself by endometrial thickness. So normal endometrial thickness is from 4 to 12 millimeter. If endometrial thickness in these patients is less than 5 millimeter, then we have to first let the endometrium be proliferated by estrogen, and then you induce the withdrawal by progestin. So it is like giving oral contraceptives cyclically, low dose OCP cyclically, will fulfill this work, and patient will have menstruation at the end of stopping those pills. If ET, that is endometrial thickness, is more than 6 millimeter, you can just give progestins for withdrawal bleeding, and you know how it works. For withdrawal bleeding, we need an estrogen primed endometrium. That is why endometrial thickness will guide. If the estrogen is already in the body and endometrium has already been proliferated by estrogen, then you just have to give withdrawal by using progestin. Never ever forget to tell them about their lifestyle modification, because this entire PCOS, all the symptom complexes, can be reversed by adequate lifestyle modification, that is diet, exercise, less usage of gadgets, less usage of lights in front of eyes after 11 p.m. What are the causes that can lead to hyperprolactinemia? The table is very important. One is physiologic. So physiological hyperprolactinemia is seen in pregnancy, in lactating females, where there is nipple stimulation, excessive exercise, stress again is very important, where you are not sleeping nicely, or in seizure disorders. Fine. Pharmacological causes of hyperprolactinemia are dopamine antagonist, phenothiazine, haloperidol, risperidone, metoclopramide, rezapine, methyl-dopa, and opioids. So you can see all the antipsychotic drugs can practically cause hyperprolactinemia and nipple discharge. Monoamine oxidase inhibitor, cimetidine, verapamil, thyrotropin releasing hormone stimulation test, if it was done for any reason, can also cause hyperprolactinemia. Then pathological causes for hyperprolactinemia are pituitary tumors like prolactinomas, hypothyroidism, chronic renal insufficiency, severe grades of liver failure, hypophyseal stack lesion, neuraxis irradiation, spinal cord lesion, hypophysitis, that is inflammation of hypophyseal stalk, and polycystic ovarian syndrome. So this table is very important because you may sometimes get short note on hyperprolactinemia. Then we think what more reasons can we write for having elevated levels of prolactin. So here is the table for you to remember. The symptoms of hyperprolactinemia may be headache, that are quite frequent, and refraction is usually normal. Patient can have lateral visual field defects, that is quite prominent and indicative of hyperprolactinemia because of the pressure effect associated with pituitary tumor, that is adenomas. If you evaluate prolactin level and it is less than 100, then medical treatment can be given. And if it is more than 100, then maybe a surgical therapy, that is excision ablation of micro or macroadenoma is required. Now, question for you is, which drug is used to treat hyperprolactinemia? Now, as we talk of systemic illness and stress, that is hypothalamic amenorrhea, which is quite common, acute and chronic stress, and systemic illnesses like tuberculosis and diabetes, where there is excessive weight loss, or in diabetes, there are so many endocrinological abnormalities already going on in the body. This can also lead to secondary amenorrhea. If you feel or if you see pelvic mass in patient presenting with secondary amenorrhea, then you again can be seeing a case of concealed menstruation. Now, question over here is, in which case in primary amenorrhea is concealed menstruation a feature? So that is again a question to be answered by you in comment section. So we'll come back to secondary amenorrhea, where there is concealed menstruation, patient is coming with pelvic mass, then probably you are dealing with a case of hematometra, that is collection of blood inside the uterine cavity. And this arises because of cervical stenosis, that is, the cervix has closed on itself, which almost always results due to surgery on cervix like conization or cryotherapy. And sometimes because of infections also. So infection-induced fibrosis can also approximate the walls of cervix or endocervical canal. The treatment is simple. You just have to dilate the cervical canal. And this is an important indication where you use Hagar's dilator just for dilating the endocervical canal so that the entire menstrual discharge which has been collected into the uterine cavity comes out. Premature ovarian failure may be a cause of secondary amenorrhea, but the patient here will be having features of menopause like hot flashes, urogenital symptoms, vaginal dryness, osteoporosis. How do you diagnose it? You do the FSH level. It will be elevated. Do it on 2 levels at least 4 weeks apart. If it is persistently elevated, then probably you're dealing with a case of premature ovarian failure. It is quite usually associated with autoimmune diseases like of thyroiditis, autoimmune thyroiditis, and these patients are at higher risk of having premature ovarian failure. So while you are dealing with them, counsel them and make them aware that this condition can be coming in future. Usually, such females are either subfertile or they must have taken multiple forms of treatment, and then they may be having low parity, and then finally they land into premature ovarian failure and menopause. So treatment is lots and lots of support and love to them and hormone replacement therapy after adequate evaluation. So now the third question for this segment is, what should be the level of follicle stimulating hormone to make a diagnosis of menopause? So to conclude, secondary amenorrhea is quite common nowadays, especially PCOS. You just treat according to cause and investigate according to the history. Because you have seen there were so many causes of secondary amenorrhea. If you do not narrow down your diagnosis, then you might be beating around the bush, doing hundreds of investigation and getting nothing probably in return. So always and always give lots and lots of importance to history, physical examination, the clinical clues, and half of your job is done when you have already made a provisional diagnosis. So next time we will be talking about primary amenorrhea, and stay connected, and you can ask question anytime and I'll be answering the queries. Thank you.